In this lecture, we'll look at psychosis and schizophrenia. So psychosis is defined as a disconnect from reality in which the patient experiences delusions, hallucinations, and disordered thinking. They are not aware that they are in a psychotic state. Can be caused by psychotic disorders, substance abuse, or other mental illness. Reality testing may be intact despite ongoing hallucinations. In other words, the patient hears voices, but knows he or she has a psychotic disorder. So that is possible. And reality testing is the process of comparing thoughts or ideas to information gathered from the external world. But more commonly, I find that reality testing is inhibited or compromised in psychosis. The most common kind of condition, mental health condition presenting with psychosis is schizophrenia. So we need to know a little bit about that because it's much more common than I think a lot of people realize. This is a chronic psychiatric disorder characterized by delusions, hallucinations, often in the form of voices or thinking or speech disturbances that last more than 6 months. There are several subtypes, and some of the more common ones would be things like the catatonic schizophrenia, and that's where patients have motor disturbances with strange posturing, incoherent speech, and they can involve extreme motion or no motion, so like being just almost looking like you're paralyzed, catatonic. Paranoid would be a patient with delusions. Often they feel they're being persecuted or followed by the FBI or the mafia or something. But they usually have better social functioning than the other types, and they actually have the best prognosis of all the different types of schizophrenia. Disorganized schizophrenia would be inappropriate emotional responses, so emotional blunting, disheveled appearance, severe impairment, and this one has a very poor prognosis. Undifferentiated have characteristics of multiple subtypes, so there might be paranoid with the disorganized. And then there is a residual subtype, and that's one or more psychotic episodes in the past, residual flat affect, withdrawal, odd behavior, thinking, but no severe psychotic symptoms. So it's more like, yeah, I have that tendency, but I'm able to function normally in life. Fairly common, affects up to 1% of the population. That's pretty huge if you look at a population like the United States. That's a big number. It's equal across all ethnic groups and countries studied. So it's not just limited to specific cultures or areas. The initial onset is usually in late adolescence or early adulthood. In males, the ages are usually between 15 and 25 when the first symptoms develop. In females, a little bit later, 25 to 35. Also a slight increase around perimenopause. Males are less responsive to the medications than females, and the females show more social cognitive deficits than males. And there's, again, a genetic component. There's 3 neurological findings. So we find there's hyperactivity of dopamine, serotonin, norepinephrine, and glutamate. Remember, glutamate causes excitotoxicity. And dopamine, though, is the main one that's kind of targeted. We think that schizophrenia has excess dopamine activity. And then there's enlargement of the lateral and third ventricles of the brain. So there's an issue here going on with cerebral spinal fluid, maybe increasing pressure. And then there's abnormalities in the frontal lobes, again, often involving dopamine excess state. So unlike Parkinson's, we can think of schizophrenia as a dopamine excess state, whereas Parkinson's is a dopamine deficiency state. The presentation, patients usually present with psychosis and disordered thinking or behavior, generally have normal memory. They're usually oriented to the person, place, and time. And the symptoms are divided into what are called positive symptoms and negative symptoms, and those are important to differentiate. So positive symptoms are thoughts, sensory perceptions, behaviors in a person with a psychiatric disorder that are abnormal within the person's culture. And that could be delusions, some can be bizarre, some are more normal. You see a little fairy in the corner of the room and so forth. Now again, when we start talking about spirit beings and whatnot, some cultures that's considered a normal sort of thing. But it's usually unusual for a person who has no experience with that and so forth. That might be considered a delusion. Loose associations with tangential speech, strange behavior, and hallucinations. These are all positive symptoms. Again, these are usually auditory hallucinations. positive symptoms of schizophrenia. Negative symptoms would be thoughts, sensory perceptions, behaviors that are present, again, in a normal person, but are absent in a patient with mental illness. And that would be social withdrawal, flat affect, monotone voice, like no emotion, lack of motivation, it's called avolition, lack of thought blocking, and then poverty of speech, alogia. So that's the negative symptoms of schizophrenia. Schizophrenia can be very similar to what we'll look at as type A personality disorders, and specifically what's called the schizotypal personality disorder. So paranoid, schizoid, and schizotypal are the three type A personality disorders. Paranoid is more suspicious. Schizoid is more the loner type. Schizotypal has similar symptoms, but they're less severe in general than schizophrenia. Also, schizophrenia shouldn't be confused with what's called dissociative identity disorder. That's multiple personality disorder. That's the new name for it. It's called dissociative identity disorder. That's a different phenomena. So that's the general presentation of schizophrenia. The DSM-5 criteria requires for schizophrenia that at least 2 or more of the following 5 symptoms have been present for at least a month, and that's hallucinations, delusions, disorganized speech, disorganized behavior, and then some of the negative symptoms we talked about. Also, the symptoms have to cause significant impairment in daily living, and the symptoms are not due to any other medical condition or substance abuse. Now, patients presenting with psychosis, delusions, hallucinations may not meet the diagnostic criteria for schizophrenia, but they can have one of the disorders listed here on the right. So brief psychotic disorder, it's like schizophrenia, but less than a month, basically, and often preceded by stressful events. So that's just a brief psychotic disorder. Schizophreniform disorder is the same as a brief psychotic disorder, but the psychotic and residual symptoms last 1 to 6 months. So just a little criteria there. And then schizoaffective disorder is schizophrenia with a mood disorder like bipolar on top of that. And so often it's difficult to differentiate. Is this like a manic bipolar that's almost becoming psychotic, or is this a mixed schizophrenia with bipolar? And that's again where mental health professionals can help differentiate that. And then substance abuse psychotic, the patient might use a stimulant and have a psychotic episode. And that's going to be different than a patient with schizophrenia. So that's the diagnostic assessment. The treatments for schizophrenia vary. There are psychosocial interventions, family therapy, individual behavioral therapy. Don't know what the efficacy rate is there. I don't see a lot of my patients benefit tremendously, at least long-term, from those. But I'm sure that's going to vary. And then the primary biomedical approach is using the antipsychotic or neuroleptic medications. And there are 2 types. The typicals, remember, the first generation, these primarily block dopamine receptors, and they treat the positive symptoms of schizophrenia better. So you might want to review that in the pharmacology notes that we went through on psych meds. More adverse effects here, unfortunately, because we're blocking dopamine. That's going to create Parkinson-like symptoms, as well as tardive dyskinesia. And then atypical antipsychotics, these are second generation. They block dopamine and serotonin. They have a better effect on the negative symptoms and fewer of the adverse effects like tardive dyskinesia and Parkinsonism. So these are more I see being prescribed for patients who are discharged from a hospital. They're out in the public, they're going about their daily lives, and they might be on an atypical antipsychotic. Versus the typical antipsychotics, that's like Thorazine and whatnot. These are given usually in institutions, hospitals, while the patient is maybe confined there. The problem with schizophrenia is that the prognosis is quite poor. There's usually a downward spiral over many years for most patients. There's a lot of non-compliance with the treatments. These medications, because of all their adverse effects, obviously are not fun to take long-term, and there could be recurrent psychotic episodes. Usually when there's schizophrenia presenting much earlier in life, like in a teen, there's going to be a lot more abnormal brain development with a much poorer prognosis. Usually when there is more community support, family support, no substance abuse, these patients have the best prognosis. Unfortunately, suicide is quite common in schizophrenic patients. Over 50% attempt suicide, 10% actually succeed in suicide. So that's something I feel like in terms of therapeutic order, we need to really go to level 4 immediately if we suspect a patient has schizophrenia, and they need to be referred to the appropriate providers. And we can work, as adjunctive care providers, work with that team to kind of help with their support. But by no means is this something that one provider alone usually can address. So just understand when you might see a patient with schizophrenia or that's maybe in a psychotic episode. Understand what kind of the classic signs and symptoms of that would be, what are the typical medications used, and then understand that it's important to make those referrals. If the patient is a harm to themselves or others, let's say they're in your office and they're becoming quite violent, that's immediate referral, that's immediate call to the police department and EMS, and that patient can actually be hospitalized under a psychiatric hold for a couple of days until they're stabilized, and then from there they could be transferred to another facility for long-term care. But that's something that's an option, and I've actually had to do that with a few patients, and in the end they actually thanked me because during that psychotic episode they had no real cognition, understanding of what was happening. Okay, so that's a little on schizophrenia and psychosis.